Respected Judge Sir, and my dear teachers present here, and all the faculties and audience. So thank you, Dr. Farhin, for giving me this opportunity to present CD in this CSI Northeast conference. So when he invited me to present a case, so initially I thought that I don't have any interesting cases. Then later on I decided that I'll present some patient with who presented with acute myocardial infarction. So I took 3 CDs actually. One who is very young patient presented with acute atrial MI, and one he is completely who is elderly lady who is completely lack of awareness about any cardiac diseases. In fact, he never visited any hospital. And one patient who presented with very normal ECG. So these 3 patients I'm going to present. I've already mentioned one patient presented with 35 years of male who is a very smoker, but he presented in time, 3 hours of duration. His BP and pulse heart rate was normal. It's a very old case actually. I did attended this patient in 2017, so I don't have that ECG, but I still remember he was having acute atrial MI, ST11 MI. So we explained the situation and did the angiogram. Right system was normal, and here is the left coronary artery. There was complete occlusion of the in the proximal part of the LED. So we explained them regarding the revascularization, and they have agreed. So we started doing this one PCI. Initially, the guide gate was creating little problem. That's why I took wear in the L6 also. Then subsequently, I did wearing of the LED. When actually at that moment it was 2000, it was done in 2017. So I thought that thrombus situation will have. So I took half of thrombosuction catheter. But as I was using the 6F catheter, it was not going. So that's why I removed the L6 wear. Then I did the thrombosuction, and large amount of thrombus was aspirated. Then after thrombosuction, you can see the flow in the LED. Then subsequently, we did the routine things. I dilated with pre-dilated balloon and then did the stenting. And we got a very good result in that patient. So this young patient, after doing revascularization, subsequently after 2 days, we have released the patient. Another patient, I said that this diabetic patient, he knows me actually. We did pacemaker in his mother. So that's why after 90 minutes of his symptom, he immediately came to my chamber directly. He was profusely sweating and he was having chest pain. Clinically, the pain was suggestive of acute coronary syndrome. ECG and ECG was absolutely normal. In fact, we repeated the ECG after 1 hour. It was also normal, no significant dynamic changes. So ultimately, we explained the situation to them, and we did the angiogram. And you can see there is very critical narrowing along with presence of thrombus in the LCX. So ultimately, we did PCI in that patient also, and we got a very good result. This was the end slide of the patient. And the last patient, Mrs. Khadija Bibi, she was, as I told you, she was the patient who is completely ignorant about his medical facilities or any cardiac diseases. But one good thing is she visited the hospital within 2 hours of symptoms. And she was very unstable in presentation. And systolic BP was 7. This was also done in 2000. The ECG quality is not that good. I have taken this from MRD record. There was ST elevation there was ST elevation in the inferior leads. So we went for angiogram, and you can see the left system. There was complete occlusion of the LAD in the origin, and there was significant proximal L6 disease also. And when we did the angiogram of the right system, you can see there was complete occlusion of the right coronary artery in the proximal part. So ultimately, we have explained the need of primary PCI in the patient. In fact, one thing I did here that by the time my guide kit and manifold and other things and Y connector were ready, I did one interesting thing here. Angiogram I did with Tiger catheter actually. As soon as they have given consent for primary PCI, I took a simple guideway and I entered the RCA with across the lesson with this one guideway, and immediately when the little pro came here, her blood pressure became above 90 systolic blood pressure. Then subsequently, I sensed it. By the time my other things, other Y connector and everything was ready, I sensed it with RCA GR 6F guide. Then subsequently, I did PCI in that patient. So her hemodynamic becomes stable, but she refused to stay in hospital for a long time. Immediately next day, we discharged her. She requested us that she don't want to stay in hospital, but by the time she was stable, so we discharged her and in a very good condition. So actually, why I presented this three cases is that one, young person is not immune to develop acute coronary syndrome, especially if there are risk factors. We all know, but it's a very important thing. And ECG may not be diagnostic in all the cases. In fact, not only initial ECG, repeat ECG may also be normal. So when there is clinical suspicion, we should go for angiogram to see the anatomy. And lack of awareness is still there in our society. Very important factor. So last, I want to say that early revascularization should be considered whenever it is possible. Thank you.